the amphitheater, but now we'll discuss with you the ECGs to see how you manage and how much do you know about ECGs generally, because you will discuss them in the lectures, in the practical lessons, and also when you are in hospital at the bedside. Okay, you are familiar with ECG. You studied in physiology and semiology, I think.
Yes.
Oh, yeah. Okay. So we'll wait more a few minutes. So, can we start? What do you think?
Yes, I think we can start. I told them to enter, and
Okay.
yeah, it's okay.
So I prepared some ECGs for you, and I will leave you about 5 minutes for each of them to analyze them, and then we'll discuss. Okay. And
Okay.
here is the first one. Just a moment. Okay.
Excuse me, Professor. If
Yes.
you meant to put the ECGs up, we can't see it. If you did mean to do it,
You don't see the ECG?
No.
Oh,
Nope.
so
No.
sorry.
just see your
Just
face.
a moment. I think I forgot to do something else. Yes, and this is what I forgot. Sorry.
It's okay.
Now you can see it?
Yes.
Okay, this is the first ECG.
It can be an ST elevation myocardial infarction.
Okay, so you finished? Have you finished?
Yes.
Everyone. Okay. So first of all, I didn't ask you for diagnosis. I asked you to describe the ECG, and then we'll see after you describe it, you can put a diagnosis or differential diagnosis. Okay. So first of all, what do you see here? It's
We start with the fact that it is a sinus rhythm.
It's a sinus rhythm, yes, of course.
There's
Something
a wide
else?
QRS.
Yes, we got there to the QRS complex. The PR segment is okay. What do you think? So it's a sinus rhythm. So the P wave has the features of a sinus rhythm. Is there a block? Is there I don't know.
There might be a first degree AV block because the PR is a bit wide.
You can measure it. Yes. Yes. From here to here. I wouldn't say it's a prolonged PR interval, so more than 200 milliseconds. So no, it's not a first degree AV block. And we get to the QRS complex, which is, how is the QRS complex?
Wide.
It's wide. And something else, do you notice?
Do we have an R prime in lead 2?
In only one lead, in V2. Okay, what you can note here, besides that the QRS complex is wide.
An elevated T wave?
Only a T wave elevated. Where you see that?
An ST elevation.
Okay, that's better. Where? In which leads?
In the inferior leads.
So in the inferior leads, which are what? D2, D3, and AVF. Yes. It's an ST segment elevation. How elevated is the segment? How many millimeters does it have? Do you know how to measure it?
Yes, but it's a bit difficult to see through the
From here
PowerPoint, yeah.
to here. So every small square is 1 millimeter. So here you can say it's about between 5 and 7 millimeters. Yes, it's very elevated. Okay, so in this condition, it's an ST segment elevation in inferior leads. And also, do you note anything else?
Skipped beats, for instance, we have single Ps.
Okay, we are discussing about the QRS complex now, and the QRS complex and this ST segment. Do you note something else?
There is something that resembles RR prime, like in the Wolff-Parkinson-White, but it's very small. I'm not sure if it's correct.
No, it's not correct. Wolff-Parkinson-White, it's with the delta wave, and you should have an smaller PR interval. and also you have.
There is
Yes, say it.
there is a depression of ST segments in
That's
V1, V2.
yes. You have also an ST segment depression in the other leads. Yes, in precordial leads, as you can see in V2, V3, and also in D1 and AVL. Yes, and so the big question is probably it's an myocardial infarction. Is an ST segment elevation myocardial infarction, or it's a non-ST segment elevation myocardial infarction? What do you think?
An ST segment myocardial infarction.
Yes, because you have both of them, and the ST segment elevation is the prime injury. The other ST segment depression is like a mirror imaging of this ST segment elevation. And because it is an inferior myocardial infarction, also you can have conduction disturbances, as you can see on the right side, because as you know, this part is recorded in the same time, and then the machine changes the leads, and that's why they're not recorded in the same time. So it's a transitory conduction disturbance. Yes, you can see here a P wave which is not conducted, it's blocked, and then it's a P wave which is conducted to the ventricle. Yes, so normally you can have inferior myocardial infarction, which can evolve with conduction disturbances, and also with when associate also the inferior ventricle, right ventricle infarction, we can have also low blood pressure. So this ECG, I want you to remember from this, it's an ST. Okay, the diagnosis or the correct answer is this ECG, as it looks, could be compatible with an ST segment myocardial infarction, because if you want to put this diagnosis, we have to have also chest pain and enzymes. Okay, so the diagnosis of acute myocardial infarction is put not only on ECG. Good?
Okay.
You agree with this or not? You don't have to agree with me, but you have to say why. So it's okay, you understood this one?
Yes.
Okay. Good. We'll get to the next one. And I leave you 5 minutes to appreciate it.
Is this a ventricular enlargement?
We'll discuss when you all finished. Yes. when you say that you analyze it, we'll discuss it. Okay. Are you ready?
Yes.
Yes. Okay. So, who wants to start? Nobody.
It's sinus rhythm.
It's sinus rhythm, and the atrial rate, what it is?
Between 75 and 100. So more to 70.
It's around 75. Okay. So it's a P wave. It's a normal P wave with the normal axis with a frequency of a rate of 75 with a normal PR interval, and it's something what draws your attention here.
There's a
you
high.
have-
Yes, yes.
Oh, Joachim, you can say it if you want.
No, please go ahead.
There's a long QRS, like a high. I don't know how to say it.
Okay, we'll get there to the QRS complex, but the axis, the electrical axis, where it is? Huh?
It's
Right axis
to the right.
deviation.
It's a right axis deviation. So that's what you will explain this. Why it's a narrow R wave. Could be a right ventricular hypertrophy. Yes. So be careful to all the clues you can note in an ECG. So it's a right axis deviation, could be a right ventricular hypertrophy. You asked me about, or somebody asked me about left ventricular hypertrophy. We don't have any signs of it. We can measure the Sokolov-Lyon index for this one. And in rest, otherwise it's not very modified ECG. If wasn't the axis, you could say it's a normal ECG. Sometimes it's very difficult. It's difficult. If you know, it could be difficult to say. Usually in exams, it say the ECG is normal. So you can get at the exam a normal ECG, not necessarily to have only pathological ones. Exams and in real life. Okay. So if we are to describe this ECG, it's a sinus rhythm, 75 atrium and also ventricles. So all the beats are conducted to the ventricles with a narrow QRS complex, with the right axis deviation and signs of right ventricular hypertrophy. You agree with this?
Yes.
Yes. Okay. Any other questions or commentaries?
Would it be considered a bit tachycardic because it's not exactly 4 spaces between?
No, why you would say tachycardic? Okay, in this particular ECG, we don't see the speed of the paper, but no, if it is a normal speed with 25 millimeters per second, so it's normal. 75 is not tachycardic. Yeah. Anything else?
No, I don't think so.
Okay. Can I go further?
Yeah.
Yeah. The next one. Voila.
Is it an idioventricular rhythm?
You are asking me? You should describe this ECG and we'll discuss with you. So this is how I would like to work with. Yes?
There's no sinus rhythm for sure because we don't have a P wave. And there's bradycardia as well.
Yes.
The T wave as well. It's pointed, it's elevated.
Okay, you are
Mirona.
Miruna. Miruna. Okay. Anything else? Other opinions? Okay, what's this?
It's the actual P wave, I think.
It's the P wave.
Yeah.
Yeah,
Okay.
I said.
So, yes.
Now I realized, yeah.
Okay, so guys, first of all, yes, you can mistake because you can say there is no electrical activity of the atrium, but here is the electrical activity, which is bradycardic. Yes, it's a sinus bradycardia. But besides this, we have a third-degree AV block, a complete block. So there is no connection between the P waves and the QRS complexes. And probably if we had a longer trace, probably somehow, because you see that the P wave, it's in different intervals regarding the QRS complex, maybe one of them could be conducted, but it's an illusion. So what you can see at the first glance at this ECG, you have P waves, which are, we can say it's normal in here you see them difficultly, yes, in precordial leads. But you have electrical activity of the atrium. It's not a paralysis or atrial fibrillation. So you can have electrical activity of the sinus rhythm. And because there is no connection between the atrium and ventricles, you can have an junctional rhythm with a rate of less than 30 per minute. Okay, so 300s, 150, 170, 60, 50, 30, 40. Yes, around 35, 40 per minute. And why do you think I said it's a junctional rhythm? It is not idioventricular. Do you have an idea? The QRS complex is not wide.
Because of the QRS, yeah, the QRS
Yes.
complex is normal.
Yes, more normal. Yes, it's almost normal, and that's why probably it's only a junction. Okay, so the heart rate measured by the machine is 36 beats per minute. Anything else? QRS axis is normal. It's positive in D1.
You have
Positive in
a
AVF.
positive AVF.
Excuse me? I didn't hear you.
I was saying that AVR seems a little bit positive.
Yes, it's quite equidiphasic in IVR. So it's positive in IVF. Where is the axis? Around 60 or 30. What do you think? So if we check the D1 and AVF, you can point that the axis is in normal range, normal in left axis deviation or right axis deviation. But this deviation means that it's over 90 or less than 0 degrees. Yes. trying to find the equity fuzzy complexes gives you a more accurate appreciation of the axis. Okay, so if you have to describe it, it is in normal range. Okay, it's normal range, so it doesn't have very. It's not very important if there is 60 degrees or 30 degrees, but if you have left axis deviation, in some books they said less than 30 or more than minus 30 is left axis deviation. So between 0 and minus 30 degrees could be normal. And you can say that left axis deviation is where the axis is situated between minus 30 to minus 90. Okay, so in this particular case, the axis is normal and around 30 degrees. Okay?
Yes.
Da, cred că e deschis. Hai că sunt aici. Okay, so you agree with me? Any questions? Miruna?
No. Yes, I
No?
think everyone agrees.
It's clear. I don't want to have questions and don't ask.
No, it's clear.
Good. Next one.
Yeah, I have a question. So
Yeah.
here, when we want to say if it's a normal rhythm or not, like if it's a sinus rhythm or not, even though the P wave is existent but not in its original place, can we say it's a sinus rhythm?
Normally, the sinus rhythm, the definition is that you have a P wave which is conducted to the ventricles, and the P waves has the features of sinus rhythm. It's not it's a bradycardia. So sinus rhythm means that also you have a rate of between 50 to 100. That's normal range. Here it is the atria are in sinus rhythm but bradycardic, and also you have a conduction disturbance between the atrium and the ventricles, and you have also the ventricles in a junctional rhythm. Yes, because the electrical activity is not let's say with the ons is not from the atriums. It's an autonomic electrical activity from the junction. Yes, so you can't say it is a sinus rhythm if you have a.
So we just need to say that it's not
You
sinus.
have to describe it. So because in many times you can have electrical normal sinus activity in the atrium, but not the conducted to the ventricle. So I wouldn't say in this particular case that there is a sinus rhythm.
Okay, thank you.
So we'll this is the next one. You ready?
Yes.
Is it tachycardia here with ST depression?
First of all, so you finished, everyone? Analyzing this
Yes.
ECG. So, first of all, what you can see on this ECG?
I think it's a tachycardia with a right bundle branch block.
Yes, the right bundle branch block.
Don't hurry. Okay. So first of all, you can see what can you draw your attention on this ECG?
We have sets of QRS complexes.
Excuse me, say again.
We have two different QRS
Yes,
complexes.
this is why I put this ECG. Yes, there is two types of QRS complexes, and from this trace, can you tell me which is the main QRS complex?
The narrow ones. I think the wider ones are premature ventricular beats.
The wide ones they are the normal ones.
No,
Okay, so can we say
The
that
fifth bit.
this one is the normal QRS complex? You agree with me or not?
Yes.
Yes.
Excuse me, one minute, excuse me. Da, Roxandra. Da, te-am sunat, ai plecat? Ok, nu, n-am terminat, dar să nu uiți să iei la chitanțierul de pe biroul meu. L-am pus pe biroul meu, nu-i semnat, ia-l ca atare și vezi ce zice și Gherghițeanu. Lili nu m-a sunat. Da, ce poate să... Da. Sigur. Bine, ok. Pa. Excuse me. So, this is the QRS complex, the normal QRS complex. So this is a P wave. You can see it. Yes. With at the limit prolonged PR interval, so could be a first degree AV block with the narrow QRS complex. Yes, this is the normal P wave, normal QRS complex with the aspect of incomplete bundle branch block. Yes, and then you can have 1, 2, 3, 4, 1, 2, 3, 4. What you would say these are?
Ventricular ectopic beats.
Ventricular ectopic beats. Very good, because you can't say anything like an atrial activity. So there are 4, one followed by another. So 4 consecutive ventricular beats with aspects of it's a left bundle branch block aspect or right bundle branch block.
It's a right bundle branch.
Right bundle branch block.
Yes, of course. Yes. So I couldn't say on this ECG how is the rhythm of this patient, because he has a normal rhythm with the first degree AV block and minor right bundle branch block, and also he has ectopic ventricular beats with right bundle branch block aspect. And if the number of these complexes is higher, we can say that there is a ventricular tachycardia, non-sustained ventricular tachycardia or not. Yes? Something else you can note on the ECG?
Do we have to say that it has a right axis deviation?
On which complex you would measure the axis deviation? Because you have two types of QRS complexes.
Yes, I think on the normal one, right?
Of course. And on the normal one, do you have the right axis deviation? Look here. It's positive in D1. It's positive in IVF. Yes, you agree with me? Because this is the recorded. So it's not axis deviation. It's in a normal range. But the patient has also frequent ventricular extrasystole, which tends to systematize, so tends to develop a ventricular tachycardia with the right bundle branch block aspect. Something else you can note on this ECG?
ST elevation, AVL, and V6.
ST elevation, where?
AVL.
AVL. Why? You are analyzing the extrasystoles? Doesn't matter, the extrasystoles. So you will analyze the rhythm for the normal rhythm. So you don't have elevation on this one. But here you can have a T wave in V4, V5, and V6. It's echidiphasic here, and it's biphasic here, and here is negative T wave. Could be something. Negative T waves.
Ischemia.
Yes, ischemia, which can lead also to ventricular rhythm disorders, extrasystoles or ventricular tachycardia. Okay, but well, you can say you have only to describe the ECG and to integrate in the patient's case. Now we are only discussing the ECG. So, does anyone want to describe it from start to end, this ECG, how it will write on a paper? How would you write the diagnosis or the description of this ECG if I gave you a piece of paper and not to write it but tell it to me? Say it to me. Who wants to try? Like a conclusion. Anyone?
I'm sorry.
Okay, go on.
At first we need to see if there is a P wave. We can't see any P wave, so we can say it's a sinus rhythm. We can see we have ventricular ectopic beats in lead V1, V2.
Okay. Till the extrasystoles you have to discuss. So we have an electrical activity like a sinus rhythm with a prolonged PR interval and the minor right bundle branch block with signs of ischemia, lateral ischemia, with T negative waves in V4, V5, V6, and also extrasystole, ventricular extrasystoles, with aspect of right bundle branch block, and we can say it's a non-sustained ventricular tachycardia. It's more than 3 extrasystoles, one after another. Yes? Sorry, interrupted you. Yes.
Can we say that we have a 4-to-1 extrasystole?
It depends. Now definitions could vary. I would say it's an yes. You're not wrong if you say that, but you need also a longer recording to see how is the rhythm correctly. Now you have only a few complexes, and from only this one, yes, you can say it's usually when you have when you have two extrasystole, one after another, it's coupled. When you have three, it's triplets. But you have four, more than four, you can say, you would say, or you should say, it's a non-sustained ventricular tachycardia. Okay.
Doctor, I have a couple of questions. May I ask?
Yes, of course.
Okay. I wanted to ask you for the extrasystole. I couldn't see it. Can you try to explain? Where is it?
Excuse me?
The extrasystole, I didn't see it. Can you try to explain where you saw it?
Extrasystole, these are extrasystoles. This one, two,
So the ectopic beats.
4 in a row.
Okay.
These are the extrasystoles. So
Okay.
normally the QRS complex should be narrow. Yes, should be narrow.
Okay.
Why
My other question.
Yes.
I have a problem with, like, I know I asked it before, but about the sinus rhythm. Like, whenever when I was explaining the EKG, you told me that we should say that it has an aspect of sinus rhythm. When do I say this, and when do I say it's not sinus rhythm at all?
Sinus rhythm, that means that the impulses starts from the sinus sinoatrial node. Yes, and it has some features. This beat should go to the ventricle on normal pathways. Yes. So if you have an electrical activity of the atriums with the features of the P wave as a sinus rhythm and with the frequency of between 60 to 100, there is a normal activity of the atrium. Then the P wave should be conducted and should be followed by the QRS complex. Okay, so a P wave and the normal QRS complex, and the QRS complex, that means it's a sinus rhythm.
Okay, thank you.
Okay? Because you can, to understand that, the atrium has electrical activity. Every electrical activity of the atrium should go to the ventricle. Ventricle has intrinsic electrical activity when it doesn't get any impulses from above. Yes, in between them there is a conduction system which gets the electrical activity to the ventricle. But also the atrium can have different points of sites, or different sites from where can originate impulses. These different sites of originating gives on ECG different views, different aspects. So it is described the sinus or the sinus node, but also you can have in inferior atrial nodes, sites, which differ from that one, the first one. Yes, and usually we have to check if there is a sinus rhythm, is the normal. We are looking for the normal activity. It is not normal. That means the features of the P wave is not compatible with the sinus. These from the sinus origin, you can have an atrial inferior rhythm. Now it's more clear than that?
Yes.
Okay. So, so you have to check this one. Okay, are you ready?
Yes.
Yes. So, who wants to?
Is it a supraventricular tachycardia?
Guys, I told you, describe it. Don't ask me. We'll discuss it. What do you see? What you will you get this ECG and tell me what you see on it and describe it as I discussed it earlier.
So tachycardic rhythm of 180 beats per minute.
Yes. Something else?
Narrow QRS.
It's a yes. That's very important. It's a narrow QRS complex. It's a tachycardia with a narrow QRS complex, 180 beats per minute. Something
high
else?
amplitude of R waves.
Okay, high amplitude of R waves. What does it mean?
I was thinking of left ventricular hypertrophy.
Okay, I agree with you, but have you measured a Sokolov-Lyon index?
Yes, it's larger. It's
How
around
much?
40.
Okay, I agree with you. So I wouldn't know if there is no. We'll measure it. Something else? Do you see that here?
Absent P.
Okay, it's a, yes. Probably you can see them. Probably is in the QRS complex. Because it's a 100 and about 300 is not. I think it's 100. You said 100, but it is 300. It's more than 180.
Yes, so that mostly suggests paroxysmal supraventricular tachycardia.
Okay, it's a supraventricular tachycardia. Okay, can we agree with this? Do you have an idea what could it be?
Could you please repeat the question?
Okay, supraventricular tachycardia could be many types of tachycardia, but can you point one?
The paroxysmal supraventricular.
Yes, okay, but which of them? Could be an atrial flutter. An atrial flutter with 2-to-1 conduction or 1-to-1. Yes, you can see this it's a high frequency here. It's a high rate here. Yes, and you have to take into account that could be also it's regular. It's a narrow QRS complex. Its rate is more than 100 and 200 per minute. So yes, generally we say it's a supraventricular tachycardia, paroxysmal supraventricular tachycardia. Okay, or could it be also a natural flutter?
Excuse me, I have a question.
Yes.
Doesn't the atrial flutter normally have the sawtooth aspect?
Yes. Excuse me. Yes, in books also, but when you can see the sawtooth, yes, that's why you ask about it. But if you have or if you want to see this, the ventricular rate should be less than 100 or 200 per minute. Yes, you see any atrial activity here? No, it's the ventricular response is very high. So yes, you're correct, but in some cases you can see that particular aspects of the P wave or P wave atrial activity, electrical atrial activity. But something else I want you to tell me about. Can you note this? What is this?
ST depression?
Yes, ST depression. Do you know why? Have you heard about ECG stress test?
Yes.
Yes. What do you think that is? What do you think they are with doing that test?
Walking
And
the
what?
treadmill?
Why? And what we wanted to see? Anybody knows? So,
to check if there's the presence of angina in a patient or
yes, not,
block.
and we don't try, we don't want to find angina. Angina is a symptom. We want to find signs of ischemia, myocardial ischemia. And on ECG, this is produced or it's shown as changes of ST segment, yes? And how we can do this? Trying to increase the rate of the ventricles in order to see if there is a lack of irrigation for the muscle. So this is like a natural stress. You understood? So in this patient, probably if it is out of this arrhythmia, the QRS complex or the ST segment is normal. But in this particular case, because of the high rate, it's equivalent of a stress test, and this produces changes of ST segment. That means that the patient could have also an ischemic heart disease. Ischemic heart disease. So we can't say anything about acute coronary syndromes because we don't have symptoms, and also we don't have enzymes. And also you can see here it's an ST segment elevation in AVR, which can be a sign of ischemia due to stenosis of the common trunk of the coronary artery, so the left main, as we call it. Have you described or have you discussed ECGs till now? I think you did on your previous not lecture in cardiology, but other classes. Yes or not?
Yes, and
Yes.
You discussed. Okay. So this was the test I gave to students. Now it's a particular way in which we are living our lives. I don't know. What is your opinion of these ECGs? They're difficult, or it is difficult ECG? What do you think?
No, but we need practice. A lot of
For everything is you need to practice. I tried to show you some because there are changes regarding the rhythm. There are changes regarding the patterns of the ECG. You have to know how to get information from an ECG. An ECG can be very important or not. In some cases, can draw your attention in acute cases, like in acute coronary syndromes. I think every one of you should know how to recognize the AV block and ST segment elevation, tachycardia, and to distinguish between rhythms on the same ECG, different rhythms. And I hope that you would do this very accurate. I don't have the intention to be all of you cardiologists, but in your daily practice, knowing more than about ECG could help you very much, and can send the patient in the right direction. Do you have any other questions? No?
I don't think so.
Yeah, okay, it's very difficult. I couldn't say so any of you. I think I was talking only with the 2 or 3. I hope the other guys were present, and not only with the name, but also were present in person here. And I think that this discussion is helpful for you. So that is what
I wanted to ask you a question. If you have any site on the internet or any resource that we can like review EKGs on, but with a small summary of what is actually in this EKG.
Okay, so ECG you can learn from every book you want. There you can find on the internet the nuts and bolts of ECGs. There's a lot of books of ECGs. ECG is known about 100 years, so not many things were changed. I will look for some sites to tell you, and I will put on the classroom. I've seen that you received the presentation for echocardiography, but I wouldn't say I recommend one or another site. So every book of ECG, and not very, let's say, like a treaty, like it's I don't know, Zipes or Chu, which are books for cardiologists. But every book, like nuts and bolts, as I've told you, it's okay. And now you can find a lot of things. I will try to find something which is not paid, probably, sites for ECG, but every site would be okay for you. It's this is for and also you will discuss it at when you will come in the hospital, and also for the not the lectures, but also in the lectures, but most of all in LPs, when we'll discuss the different cases of the patients, and also we'll have ECGs to describe of the case. I think I hope that it's okay for you. Anything else?
I wanted to ask you something not related to this course.
Yes.
I saw that you posted the presentation from yesterday.
Yes.
Are we gonna have the presentation from Friday as well from Professor Koman?
Yes, I think you should ask him, and if he's agree.
Yes, he told us that we're gonna get them,
Yes.
but I was just wondering if you could just post them in the classroom.
Yes, I have to ask the professor to give me the presentation and to put it on classroom.
Yes, I think we did 3 presentations on.
You have also an email on which we can stay in touch. Yes. And everything asked and will be responded. Will be answered. Yes.
Yes.
Okay.
Thank you so much.
You're welcome. Have a nice day, and good luck at studying.
Thank you. Have a nice day.